So if Dr. Sullivan could get her slides up and ready to go, it gives me great pleasure to introduce my colleague and long-term friend, Dr. Shelby Sullivan, who's Associate Professor of Medicine. She's the director of the Endoscopic Metabolic and Bariatric program here at the University of Colorado. And she has been active in this space ever since she was a fellow. So it gives me great pleasure to ask her to speak today about endoscopic sleeve gastroplasty, how I do it. Dr. Sullivan?
Thanks so much, Steve, and thanks to Mihir and to Christy Click for putting all of this for this course together. And these are my disclosures. So you've heard a number of talks today, one of them really focusing on the space occupying devices and some of the non-intragastric devices. We're going to be talking about endoscopic sleeve gastroplasty today. So again, really focusing on the suturing and plication devices. However, since this talk is focused on how I do it, we are going to be focusing on the overstitch device because that's the device that I have available to me at the University of Colorado. And I'm going to be showing you a lot of data today that's actually from Dr. Thompson. And as Dr. Edmundowitz said, he really is really kind of the father of endoscopic bariatric therapy. So we're going to first talk about how endoscopic sleeve gastroplasty really evolved. So one of the first publications on a type of suturing in the stomach was from Fogel. This was an open label single center study where they used the barred endostitch device. You've already heard about that. It's not a full thickness device. This procedure took about 45 minutes, didn't include the greater curvature. They had excess weight loss of about 58% at 12 months. And in repeat endoscopy at 3 to 12 months after the index procedure, sutures were intact in 5 patients, but were loose in 6 patients and disrupted in 3 patients. So it seemed like, that this wasn't quite as durable as we would have liked. So Dr. Thompson also was involved in another study using an updated version of the barred suturing system. And this trial was called the TRIM trial, the Transoral Gastric Volume Reduction Study. And it was, again, an open label single arm study with 18 patients. And they used this device and they placed an average number of 6 plications. It took about 2 hours. They had an excess weight loss of 27.7%. They had no serious or procedure-related serious adverse events. And at follow-up, EGD, they had partial or complete release of plications in about 13 patients. So again, really demonstrating the need for an updated device, which eventually came, again, with the overstitch device, as Dr. Thompson talked about for endoscopic revision. And this is Dr. Thompson's group kind of evolution of the full thickness suturing. And so they published this recently, the different phases of development of this technique. And phase 1 was a procedure that was created to improve time efficiency. They had 5 patients in India with replication and 23 patients in Panama and the Dominican Republic. And one of the things that they did is they sutured from the antrum to the fundus with 6 to 12 bites per overstitch. They had total body weight loss of about 13 kilograms, and their total procedure time was 120 minutes. In phase 2, they had technique refinement. 22 patients at 2 centers in the Dominican Republic in the US. They used CO2 instead of air. They only used 6 bites per suture, and they did use reinforcing interrupted sutures that were placed. They also didn't necessarily use APC for marking in all of the procedures. Total body weight loss was 17% at 12 months. In phase 3, they were looking at evaluation of feasibility and weight loss. They had 77 patients total with a weight loss of 17.4% total body weight loss. And you can see in the pictures here the drawn image of the suturing plus the reinforcement, and then the pictures of what it actually looked like in the stomach itself. And so the next thing that we talk about really is suture pattern. So this is another evolvement of this procedure. And there's a number of different procedure or stitch patterns that have been proposed. There's the triangle pattern, the Z pattern, the U-shaped pattern, the rectangle pattern where you start in the greater curvature and end in the greater curvature, which is meant to reduce the risk of having cinch or needle placement in the way of a sleeve gastrectomy in case the patient wanted to go to a surgical procedure. Also, we talk about suturing in the fundus. So that was one of the things that was done initially, but is it worth the hassle? And this study was a retrospective analysis from 2 centers that looked at sutures in the fundus versus no sutures in the fundus. And what they found at 12 months follow-up is that there was 66 patients in the sutured fundus groups, 57 patients in the no sutured group, and there really was no significant difference in weight loss between the 2 groups. And when you look at things like adverse events, procedure time, there was decreased procedure time when there was no suturing in the fundus, and that was statistically significant. Also, fewer sutures were actually used. But there was no difference in serious adverse event rate, and again, no difference in the weight loss or safety of the procedure. So what about a reinforcement row? During that evolution, there was a reinforcement row that was placed, but there was this prospective study, or this opinion review article that was published looking at how to minimize adverse events in endoscopic sleeve gastroplasty. And so one of the things that they recommended in this review was to potentially not do a second row of sutures or a reinforcement row of sutures. And the reason for that was because gastric wall is tense at that point. You've already put a first row of sutures in and is less pliable. There's also reduced maneuverability in the stomach. It's already smaller by that point, and potentially increased bleeding. So there's different differences in opinion of reinforcing row or not reinforcing row, again, because of these potential issues. So the weight loss that we're seeing, though, regardless of how people are actually doing the procedure, when we look at single center experience, this is kind of the longest data that we have for endoscopic sleeve gastroplasty in 216 patients. At 12 months, they had 15.6% total body weight loss, and 77% of patients had more than 10% total body weight loss. At 5 years, they still had 15.9% total body weight loss, and 60% of patients were maintaining more than 10% total body weight. They did have some patients that were started on weight loss medications, and that just highlights the importance of really comprehensive care for these patients, and moderate adverse events occurred in 1.3% of patients. In a meta-analysis that was performed, including 1,772 patients, there was weight loss of 16.5% at 12 months, and at 18 to 24 months, there was 17.2% weight loss. Serious adverse event rate was 2.2%, but half of those were really related to accommodative symptoms, nausea, vomiting, dehydration, requiring IV fluids, IV anti-nausea medication. So with all of that said, so what do I do? How do I actually do it? So during the procedure itself, I usually use 8 to 10 bites per suture, and I use a U-shaped pattern. I do anterior to posterior and forward-facing view, but I actually do the posterior to anterior and retroflexed view, and I'm going to show you why I do that in a minute. I do use a reinforcing row, either interrupted V or occasionally I do a U-shape with just 4 bites. And I don't do any suturing in the fundus. The fundus is typically pulled down with the rest of the procedure, and so you don't really need to put sutures in that fundus. But I also really do things in the pre and post procedure time in order to really try to enhance weight loss. Number one is careful assessment of the patient before we actually do the procedure, and evaluation for obesity comorbidities. We also want to prevent symptoms and complications in these patients. And then I use moderate to high intensity lifestyle therapy. We offer high intensity lifestyle therapy. Most patients are really getting moderate intensity lifestyle therapy with the number of visits they're actually attending. And then we monitor patients for weight loss and escalate therapy for inadequate weight loss when needed. We're going to talk about this in a minute. So first thing is the forward-facing view versus retroflexion for the posterior to anterior bites. So what we think we're doing with a U-shape is on the left. We think that we're taking bites and we're going through smoothly all the way from the posterior wall to the anterior wall and then back from posterior to anterior. And our goal here is really the suture moving through the tissue in a line. But really what happens when you stay in that forward-facing view, because your tower is on the left and the suture is always moving through the tissue from left to right, that in the forward-facing view, going from the posterior wall to the anterior wall, you're creating loops in that tissue when you pull tight. So it's not as smooth as you actually think it is. And I'm going to show you that here in a video. So this is how I do my procedure. In this particular patient, we had some initial issues with the suturing device itself. So there was a little bit of bleeding there to begin with. But you can see when we're putting these initial row going from anterior wall to posterior wall, that the suture is moving through smoothly through the tissue. There's no loops that are being formed here. And you'll see just one more that we're putting in here. But you see that the tissue, sorry about that. Let me slide this again. There we go. Sorry about that. That tissue is going through, the needle is going through, and that what you can see on the left-hand side here is that you have that suture that is on your left-hand side, and it's going from left to right through the tissue. And you can see here, I've finished my row of sutures going from anterior to posterior wall, and now I'm retroflexing to do my posterior to anterior wall sutures. It's a little bit less room, and you'll see that what we'll do is you still see that that suture is on the left. You have no suture in your view, in where you're actually going to be pulling tissue in to throw your bite. And now that suture is still going through smoothly. There's no loops that are being formed here. And I'm just going to fast forward this so we can see kind of what we have with the completion of that row right there. And then just to show you, this is the completion of the actual first row of sutures. So you see that we're coming up, we're staying below that GE junction. This is the first row of sutures that have gone in. And now I'm putting in my second row. And in this particular patient, we did interrupteds for all of that second row of sutures. And you can see here, I do feel like I had enough mobility and enough pliability of that tissue. And that's just the distal part of it. So you can see that we've got a nice reduction right at the beginning of that sleeve. And this is what the actual rest of the procedure looks like at the end. So this is after both the first and second row of sutures. And in this particular patient, she had a weight loss of 17.4% at 6 months. Her goal is to get under 200 pounds, and she's on her way there. This is a different patient at 4 months after endoscopy. There is some loosening of the reinforcement sutures, but we have that very much intact first row of sutures. And this patient had 16.5% total body weight loss at 6 months. So next, kind of moving on to the other things we do. The procedure itself, yes, it's very important, but all the things that we do around the procedure are also really crucial. So this is kind of a template of what my templated note looks like in Epic. So one of the first things that I do is during my actual initial visit, I'm doing a patient health questionnaire. Does this patient have depression? If they do have depression that's uncontrolled, that will affect their ability to lose weight. The other thing I do is the questionnaire on eating and weight patterns. So I screen patients for eating disorders. Again, if a patient has binge eating disorder, they are going to be less successful with any endoscopic therapy. You do want to get them treatment if they have that. The other things that I do is look at barriers to exercise. And if they have that because of pain or other issues, we send to physical therapy. If there's evidence of obstructive sleep apnea, I do a home sleep test and refer to sleep medicine if they have moderate to severe obstructive sleep apnea, because they do need treatment if they have moderate to severe obstructive sleep apnea. It can actually prevent them from losing weight. If they've got mild obstructive sleep apnea, I usually don't necessarily need them to start CPAP, because they're just with a small amount of weight loss, they may see reduction in their sleep apnea. If they have a high stress score or a high score on their PHQ-9, I refer to psychology for additional therapy, again, to aid in their ability to be able to lose weight and focus on behavior change in order to lose weight. If they have an eating disorder, again, I definitely, if they screen positive for it, I send them to a psychologist and may need to start medication for treatment for that as well. If they have GERD or dysphagia, I will do an upper endoscopy, diagnostic upper endoscopy, before I do any endoscopic procedure. The other thing is managing symptoms pre and post procedure. So the first thing is we use a lot of medications before the procedure. Omeprazole that I start 1 week before the procedure, scopolamine patch, a Prepitant that I give 4 hours before the procedure or the night before the procedure, ondansetron that we use after the procedure and during the procedure. And then I also do give patients some additional medications to take if those medications are not sufficient to suppress their nausea. We really don't want people vomiting forcefully to really disrupt any of these sutures. So I will give them just a few tablets of lorazepam in order to help them sleep at night and to reduce that nausea and vomiting at night. I do give a small amount of pain medication. I find about 50% of patients may use this. There is sometimes pain underneath that I think is from gas escaping from the lumen that goes underneath the diaphragm that causes pain. That pain is usually gone within 24 hours. And then I also give anti-cramping medications as well. During the procedure, we give 2 liters of lactated ringers, or if they don't have heart failure or diabetes, because we want to make sure that we're topping them off before they leave. We do give IV medications during the procedure, dexamethasone, ondansetron, and we also give antibiotics during the procedure as well. Typically, my anesthesia providers also use a TIVA, or total intravenous anesthesia, so that we avoid the nausea that can be caused by the anesthetic gases. We also place sequential compression devices to prevent the risk of blood clotting. There have been a few cases reported of blood clots and PEs in these patients after suturing and endoscopic sleeve gastroplasty. For the diet, we have a really prolonged diet modification. We have 72 hours of clear liquids, and then we do full liquids for a full 6 weeks before going on to pureed food. So the next thing that's really important is the behavior coaching that you give to these patients afterwards. And this has been demonstrated over and over again. This is with lifestyle therapy alone, looking at the Pounds Lost study where they evaluated multiple different diets for weight loss. And really what they found is that there was no difference in the weight loss, but there was a significant difference in weight loss depending on how many visits you had with the behavior coaching team that were part of the study. This is also seen in endoscopic bariatric therapies as well. So this is a series of studies of a different suturing device looking at the incisionless operating platform with the pose procedure. And we can see with low intensity lifestyle therapy, there was little weight loss. With the same procedure with moderate intensity lifestyle therapy, we see that there was significantly more weight loss. So that behavioral therapy is really important. And what we do in our practice is we have both individual sessions with our dietitian and group visits with group sessions with our dietitian that we have, and we offer that throughout the entire first year of the procedure. Most patients at least go to their individual sessions, and probably half of patients do the group sessions as well. But that allows us to get at least moderate intensity lifestyle therapy for most patients. But again, we have we are giving them high intensity lifestyle therapy, which is really defined as 14 or more visits with your team within the first 6 months. Moderate intensity is more than 6 visits in the first 6 months. So what are the other things that we look at? Well, what weight loss, because we're really trying to prevent those patients who may be poor responders from not achieving their weight loss goals. So at what point are we actually looking at doing something more? So first of all, we expect about 16.5% total body weight loss at 1 year. Highest rate of weight loss, and this is true for almost any procedures, in the first 3 months of therapy. And there are predictors of higher total body weight loss. So total body weight loss at 1 month is a predictor, and compliance with behavior coaching is also a predictor. So in my practice, I check weight loss at 1, and I see patients in clinic at 1 month and at 3 months. And if weight loss is less than 5% total body weight at 1 month, I add therapy. And if it's less than 10% at 3 months, I also add therapy. And that could be increasing their lifestyle therapy or their intensity of lifestyle therapy, or adding a medication. And there are other things that we look at too. So I'll do a full evaluation with factors associated with weight gain, stressful events, injuries, things like that. I do a diet recall. I ask them about exercise, their adherence to behavior modification. We also go back and look at depression. Are they having some worsening of depression or something else going on? Patients frequently will use food to treat depression or stress. So we definitely want to talk to patients about that. And then we assess them for weight loss medication. And there have been multiple medications that have been used that have been demonstrated to increase weight loss after endoscopic sleeve gastroplasty. This was a study out of Cornell that showed they used multiple different medications, but what they ultimately showed is that weight loss increased from 10.8% before medication to 14.9% after medication in patients who had less weight loss or inadequate weight loss with endoscopic sleeve gastroplasty or weight regain. There's also a study that looked at propensity score matching in patients who were offered liraglutide 5 months after endoscopic sleeve gastroplasty. And they had 26 pairs of patients, essentially 26 that had ESG alone and 26 that had ESG plus liraglutide. And they were, as you can see in the table, very well matched in terms of age, sex, weight, BMI, and other comorbidities, including prediabetes. And what you can see in the graph is that when they started, the weight loss was similar between the two groups until month 5 when they started liraglutide, and then they separate out. And you get about 5% more total body weight loss with the combination of medication plus ESG versus ESG alone. So in conclusion, there was an evolution of ESG techniques over time. Current ESG is really safe and effective. Patient treatment is as important as the procedure technique. You want to reduce complications, but also catch and treat inadequate weight loss early. Thank you.
Great, Shelby. Thank you very much for a really nice presentation. I'd like to comment that all of the speakers really did a great job this morning, not only staying on time, but covering the topics well.